हेलो हेलो हैं रुक रुक हम अभी बाद में बात करते थे
And now, obviously, we begin with the most important group of acquired cataract, that is senile cataract or age-related cataract. Why am I calling it the main group? Why? Because senility means old age. I am going to become old. You are also going to become old. Everybody will become old. And that basically means cataract, because it is senile, it is actually going to occur in everybody. Yes. If you didn't realize this, realize it now. It has occurred in your grandparents. It is going to occur in your parents soon. And based on the habits you have, it is going to occur early in you only. Yes. And that's the truth. Our grandparents used to have it at 70-ish. Our parents are having it at 60-ish, and probably we will have it earlier still. Let us see, only time can tell. Even though I've said it will occur in everybody, if you're wondering why it will occur in all of us. So I can show you an image. I can show you the risk factors for cataract, out of which you can see the first risk factor we are saying is increasing age, or I can say old age. And what is the pathomechanism behind it? It is written oxidative damage to membranes and proteins. All right. So there is oxidative. As we age, we know the antioxidants decrease, the oxidative stress increases, and that is the same reason for cataract. You will see various other causes written or of cataract. One of which is very important. If you don't know, I'm marking it for you: corticosteroids or steroids. And steroids, cataract due to disturbance in the balance of the proteins. All right. Then you will see various other causes such as ultraviolet radiation, which can also lead to cataract. This is due to hydration, which we will discuss later on. All right. Now, moving back to senile cataract or age related. What do we know about senile cataract? We know senile cataract occurs in old age. So, what is old age? That is my question to all of you. What is old age? Old age means yes. So, I don't know if you know, senile in Hindi, if we convert this word senile, it means satya jana. People who know Hindi, I know it is funny, but senility actually denotes 60 years of age. The same we say in Hindi, yes? So we are saying senile cataract means the mean age will be around 60. That means it can occur any time. The onset can be any time between 50 to 70 years of age. The presentation obviously will depend because it is gradually progressive. People who are educated present to you earlier than people who are uneducated, yes? So the old age presentation is 50 to 70 years of age. Also remember that senile cataract shows anticipation phenomena. Anticipation phenomena is present. What is anticipation phenomena? Anticipation phenomena means if you have hereditary cataract and it is occurring in old age, it is going to appear earlier because you are anticipating that, and you can anticipate it will appear earlier. Yes, that is basically anticipation phenomena. Now, please remember that senile cataract is of four types. Okay, what are the four types? Based on the site, I will write it based on site. So, we start with number one first. The first type of senile cataract that we are going to study is nuclear cataract. I don't think I need to crack the joke of a nuclear war now. You know enough by now. Yes, you know that nuclear cataract means the cataract will occur in the nucleus, or the opacity will be in the nucleus. If the opacity is occurring in the nucleus, can I call it central cataract? Yes. If we know the anatomy, which we know, yes, we know, I know, we know. If we know the anatomy, we know the nucleus is in the center of the lens. So I can call it which cataract, guys? I can call it central cataract. Now, if it is a central cataract, yes, if it is a central cataract, what will the patient complain of? I'm giving you two options. Does the patient complain of more loss Hear my words. I'm writing them here. More loss of vision in daytime, or does the patient complain of more loss of vision in night? Due to the fact that it is central in position. More loss of vision in daytime or more loss of vision in nighttime? Yes. Lot of you are saying it correctly if you have thought about it. Patient complains of more loss of vision in daytime. But my question is why? Why does the patient complain of more loss of vision in daytime? Central cataract, daytime. If you are thinking about cones, you are wrong. If you are thinking about cones, you are wrong. If you are thinking about pupil, then you are right. Let us see. This is my cornea. This is my pupil. We know the basics. If not, then please go back and watch the basic videos about pupil. In sunlight or in bright light conditions, pupil remains constricted. Where is the cataract we are saying? We are saying that the cataract is in the center of the lens, in the nucleus. Let us see the condition now. If the cataract is in the nucleus, the light ray which travels, it will travel through the center of the iris, that is the center of the constricted pupil. It will have to travel through the center of the lens, but because the lens has a central opacity, you will not be able to see in the daytime. But come night, in night my pupil will dilate, yes. In night my pupil will dilate or my pupil aperture will become dilated. That means now the light rays will be able to go through the center as well as the periphery. Central light rays will be blocked, but peripheral light rays will be able to form an image on the retina. So what is the patient telling me? Patient is telling me, sir, I have more loss of vision in daytime. Or actually, if I can tell you, patient is saying, patient is complaining of improvement of vision during night. Or I can say during dim illumination. That's the word that the question will use. Improvement of vision during dim illumination, when the pupil will dilate, allowing the peripheral light rays to form an image on the retina, blocking only the central rays. I hope I'm pretty clear here. Yes? Once you understand this simple phenomena, the second thing I'm asking you is the pathology or the pathogenesis. What is the pathologic change which leads to development of nuclear cataract? The answer is one word. Yes, a lot of you know that. I already know. And I'm writing it here. No, I don't know. I know that you know. The problem is I know what you know and what you don't know. And the problem is you don't know what you don't know. Because you don't know what you don't know, you can't study what you don't know. And that is why you always miss that. And you keep on wondering what we don't know. Pathogenesis. What is the pathologic change which leads to development of nuclear cataract? The answer is one word. Yes, a lot of you know that. I already know. And I'm writing it here. I don't know. I know that you know. The problem is I know what you know and what you don't know. And the problem is you don't know what you don't know. Because you don't know what you don't know, you can't study what you don't know. And that is why you always miss that. And you keep on wondering what we don't know. Alright? So to know what you don't know, you need to know everything. Once you know everything, then only you will be able to point out what you don't know. Alright? I know it was a lot of bakwas, I know, yes, I keep on doing this. I told you already, PJs, that's my forte. So the pathology is sclerosis, guys. Sclerosis. Sclerosis means sclerotic changes, denaturation of proteins. We are making the cataract more hard. We are making the density of the lens harder. The density is the right word. I can't explain it to you. Yes, sclerotic changes, density. It is becoming more rigid, more hard, more dense. Now, when the lens is becoming more dense or more hard or more rigid, what is the problem due to it? If you remember, the maximum refractive index was in which part of the lens?
Nucleus.
The maximum refractive index was already in.
Nucleus.
Maximum refractive index was already in, yes, the center of the lens. Now that center of the lens or the nucleus is becoming harder. So I can say refractive index of the lens increases. Refractive index means hardness. Refractive index means density. Air is 1, I or lens is 1.406. Now it is becoming more sclerotic, more dense. The refractive index is increasing. What will occur because of increase of refractive index? If you know your physics, you know this is air. The refractive index of air is 1. This is lens. The refractive index of lens is 1.406. That means light rays have to travel from a rarer medium to a denser medium. When light rays travel from a rarer medium to a denser medium, light rays converge. Okay? So that is how our eye has been made, that it converges onto the retina. But now what is occurring? This is becoming more dense. More dense means the convergence will increase. The convergence will increase means the parallel rays of light which come from air, they will be able to converge with more power. More power means they will converge before the retina. So basically we are saying that if the refractive index increases, the power of lens increases. Because of increase of power of lens, image forms in front of retina known as index myopia. This is known as index myopia. Alright? When the image forms in front of the retina, it is called as myopia. When it forms behind the retina, it is called as hypermetropia. Please see the optics videos to know the basics of this. Alright, everybody? Now, what is myopia?
हेलो ठीक है
myopia? Again, I hope some of you know at least. Myopia means, I actually already told you, myopia means loss of far vision. Hypermetropia means loss of near vision. This we've already discussed. National highway, near vision hypermetropia. Yes. Loss of far vision is also known as nearsightedness. Myopia, loss of far vision. So basically what we are saying is due to sclerotic changes, that means increase in density, because of increase of the refractive index, there is image formation in front, which is leading to loss of far vision. But when we are losing far vision, we are developing nearsightedness. Now, because of index myopia, because of the fact that we are developing nearsightedness, patient develops, or I'm saying leads to, myopia leads to second sight phenomena. Second sight phenomena. What do you mean by second sight? Imagine you are 40 years of age. At 40 years of age, you develop presbyopia. Yes, do you remember this word?
Yes.
Presbyopia
Loss
is
of
meant for
accommodation.
linear vision glasses. Now, when we have developed presbyopia at 40 years of age, you have been wearing reading glasses to look at your mobile for the past 20 years. Today, you are 60 years of age. For the past 20 years, you have been needing glasses to read your mobile phone. But now, you have developed nuclear cataract. Due to nuclear cataract, you have developed index myopia. Due to index myopia, you have actually lost your vision for far. But as soon as you developed index myopia, you have lost your far vision, you have actually developed nearsightedness. So now, at 60 years of age, something funny is happening. And you're telling your husband, wife, children, everybody, your family members, that something funny is occurring. For the past 20 years, I've been using a pair of glasses to look at my mobile phone. But now I can look at my mobile phone even without the glasses. So you are saying something magical has occurred. My near vision has come back again. And if it has come back again, you are saying it has come back for the second time. And that is why you are calling it second sight. A layman cannot understand that they have developed a cataract actually. Yes, they are just happy over the fact that they have regained their near vision. That is what you need to explain to the patient. Alright? So what is second sight phenomena? Improvement in near vision due to nuclear cataract in a presbyopic patient or in a hypermetropic patient. Both ways, hypermetropia also means loss of near vision, yes. So in both the cases, but the prerequisite is ideally that you should have had presbyopia. That means if you develop nuclear cataract in 20 years of age or 30 years of age, due to some reason, unexplainable reason, you are not going to have second sight because you never lost your near vision. So you should have lost your near vision to regain it. Yes? Am I clear? Done. Alright. Now, once you know this, I will ask you what is the color of nuclear cataract? See, this is a question which is a third year posting question. In third year clinical postings, we give you a torch, and through that torch, we ask you to examine the color of the lens of the patient to tell us which type of cataract is it. Is it cortical cataract, nuclear cataract, what kind of cataract it is. So, anybody knows what is the color of the nuclear cataract if you've examined a case ever? White if you are saying you're wrong. See, again, that means you have attended your posting but you have never paid attention to it. So the white is all for cortical. Yes. Nuclear cataract is not white. Nuclear cataract is, yes, very good. Nuclear cataract is yellowish in color. Grade 1 is yellowish. Then it turns dark orangish. We are calling it grade 2. Nuclear cataract is clear cataract if you've examined a case ever. White if you are saying you are wrong. See, again, that means you have attended your posting but you have never paid attention to it. So the white is all for cortical. Yes. Nuclear cataract is not white. Nuclear cataract is, yes, very good. Nuclear cataract is yellowish in color. Grade 1 is yellowish. Then it turns dark orangish. We are calling it grade 2. Then we say it becomes more progressed, grade 3 brown. And if you don't treat it by the time it is grade 4, it is black. When it is black, you give it a specific name called as cataracta nigra or nigra, then cataracta brunescens. That's the name for brown cataract. Okay? Usually, when we see a case of nuclear cataract, we either see it in grade 1 or in grade 2. Okay? Now I'll show you the photographs of this. Let us see this first photograph. Okay. This is a photograph of not a cataract, a normal lens. I'm trying to explain you what is this. This is a photograph of oblique illumination. I will try to explain this photograph to you to the best of my abilities. If you don't understand it, please, at the end, in the annexure videos, you will find a video on oblique illumination where I am trying to explain it to you through an instrument called a slit lamp. Okay, now, let's say you're not watching that video. There's a slit lamp. Slit lamp is a machine which throws light onto the eye in the form of a slit. Slit means when we usually throw light from any source or a torch, it is a dot-like light. It is a round light, dot-like. Here we are not talking about dot-like light. We are talking about a vertical slit of light. Slit of light supposedly goes like a knife. Yes? When you throw a slit of light, let's say it is a knife of light which can completely dissect the eye. So it can show me all the planes, all the depth inside the eye. That is what we do when we do slit lamp examination. So now imagine that I am throwing light from this side. Okay? It's an oblique illumination. Oblique slit illumination, I will write. Now, obliquely when I'm throwing light, first of all, that light is shining onto your cornea. So I know this is the anterior portion of the cornea, this is the posterior portion of the cornea. Then, even though the pupil is dilated, I can see inferiorly some orange-brown color tissue. That means this is my iris. See, light is going in. Then it goes in further. And further, behind the dilated pupil, I will have the lens. I can see the complete anatomy of the lens. This is the anterior portion. In the center is the nucleus. This is the posterior portion. So that is the beauty of slit lamp examination. I can see the depth. I can see the exact position of any lesion. That is what we need to do, everybody, when we are talking about diagnosing the site of cataract. Let us see how. Now let us see this image. Same thing. I throw light from this side. First of all, I see the corneal slit. Then obviously the iris must be dilated. This is the pupil at the anterior chamber and the posterior chamber. Now I see the lens. This is the anterior capsule of the lens. Now see, this is the nucleus. This must be the cortex. Now you see the nucleus has become orangish, yellowish in color. That means I am looking at a case of nuclear cataract. Somewhere around grade 2, maybe progressing towards grade 3. Am I making myself very clear here? Yes, that is how we are able to see. Please try to get your head around it. If not, then I have to stay able to discussing this oblique illumination technique in a lot of topics like glaucoma and everywhere else also, because everywhere we need to see the signs in the eye through oblique slit lamp illumination. Alright, now, why does yellowish color occur? Why does yellowish color occur? That's the question number 2. So yellowish color occurs due to deposition of urochrome pigment. There is a pigment called as urochrome. Urochrome means color like urine, yellowish color. Urochrome pigment is derived from tryptophan amino acid. Okay? Now, what will be the problem due to yellowish color? Imagine, your and my lens are absolutely transparent. That is why the world we see is completely transparent. But if your lens were to become yellow in color, what would have been the problem? Would your world have been clear or would your world have been yellowish? Patient complains of yellow colored vision. Yes or no? Yellow colored vision is known as xanthopsia. We have heard of this word earlier in color blindness, in causes of acquired color blindness. If you remember xanthopsia, in old age and due to sildenafil, blue color blindness leading to yellowish color thing known as xanthopsia. The same thing is occurring here. Yellow color vision known as xanthopsia. Xanthopsia word is derived from the xanthophyll pigment. Plants have two types of pigment: chlorophyll green in color, xanthophyll yellow in color. Xantho means yellow. Xanthopsia. So that means from the color part there are 3 questions for me. It is yellowish in color, urochrome, xanthopsia. I'm trying to tell you that even though I've drawn it in or written the points in concise manner, in flowchart manner, but there are lots of questions. 3 questions from color, lots of questions from pathology. Why does it occur? Sclerosis. What is the change which occurs in the lens? Refractive input lens of the increases. Which refractory error occurs? Index myopia. Second sight phenomena is seen in nuclear cataract. Where is nuclear cataract present in the center? What does it cause? Loss of vision in daytime, improvement of vision in dim illumination. So lots of questions are there. I have tried to tell it to you under 3 points to make you understand that it is easy to remember a lot of concepts through 1 point also. 1 point can develop into 4 questions. Alright? We are discussing senile cataract, everybody. The first type of senile cataract has been discussed with you, that is nuclear cataract. And now we move on to the second type of senile cataract, that is called as cortical cataract. Cortical cataract, as I hope you will be able to understand from the name itself, cortex. Cortex is present in the center or in the periphery of the lens, obviously periphery. So that means it is different from the first variant that we have studied. Nuclear was a central cataract, but cortical is a peripheral cataract. Now, if you understood nuclear cataract causes loss of vision in the daytime, I hope you understand that cortical cataract, because it is peripheral, will cause more loss of vision, or I can say patient complains of more loss of vision in nighttime slash dim illumination. Why? I hope it is pretty clear. In the nighttime or in dim illumination, when the pupil has to dilate to allow extra light to go inside, because of the opacities in the periphery, extra light will not be able to go inside, and that is why there will be loss of vision in nighttime. Now, please remember, loss of vision in nighttime is known as, yes, obviously I know night blindness. Yes, that's pretty easy. But what is night blindness known as? Very good. Some of you are saying it. We used to read this word in physiology, guys. Patient complains of night blindness, which is also known as nyctalopia. Okay. Now, what is the pathology? So the pathology is one word, like nuclear cataract, but very different. In nuclear cataract, that one word was sclerosis. Whereas in cortical cataract, that one word is hydration. Hydration. That means cortical cataract is occurring due to fluid accumulating in the cortical area of the lens. Now, sclerotic changes made the lens hard when you are talking about nuclear cataract, but fluid coming in, will it make a substance hard or soft? Obviously, yes. So if you understand, this is a very important morphological difference. When you are doing a surgery to remove cataract, if there is something hard, it is difficult to remove. Nuclear cataracts are difficult to cut and remove. Whereas if it is a cortical cataract, you can just suck it. It is a soft area, you can suck it, right? So that is where you need to know these morphological differences. When you are operating on a patient, you need to diagnose correctly which type of cataract it is. Now, what does hydration cause? Hydration leads to formation of water clefts and vacuums. Question is asked, what is the earliest pathologic change seen in cases of cortical cataract? And that is what the answer is. Formation of water clefts and vacuum, straight line. Very easy. See, when fluid is coming in, it is forming small, if I can say so. Diagrammatically, I don't think it will be a correct representation when I'm drawing, but still I'll try to explain it to you. Let's say this is my rough diagram, this is my nucleus, this is my cortex. So within the cortex, there will be small fluid filled areas. Can I say that? So water clefts and vacuums. Now, when these water clefts and vacuoles, they will enlarge, they will become larger, they will coalesce. When they coalesce, they lead to lamellar separation. What do you mean by lamella? Lamella is an English word which means layers or sheets. Yes. So all the fibers, we saw the arrangement of the fibers. I'll go back to the image. I don't know if you remember it. We saw that all these fibers are arranged in sheets or in layers, I can say, yes. We saw that they are curved fibers, yes. So there are curved fibers in the cortex also. So now what will occur between two sheets of cortex? What is going to collect? Fluid. So what are we trying to say? That between all the lamella or sheets of cortex, fluid is collecting, and thus we are saying it is separating the lamella. So I'm saying separation of sheets of lens fibers by fluid. Yes? Now, this is kind of a morphological change which is occurring. I hope you understand when the structure is getting changed by fluid, it will lead to the formation of opacities. Yes? So now we see wedge shaped opacities in the periphery. So till lamellar separation, I can say this is basically a subclinical change, but after that, due to that, the clinical change appears when we start seeing opacities for the first time. When wedge-shaped opacities are seen in the periphery, this is known as cuneiform cataract. cuneiform cataract. Alright, now, cuneiform cataract, if I can show you by drawing the diagram, if this is the pupillary area from which lens is visible, I need to know two things. Number one, the opacities will be what shape? Wedge. Wedge is a triangular shape, wedge, okay? Then the cataract will be in which part of the lens? Periphery. If I remember these two words, I see the diagram, I will be able to understand very easily what cuneiform cataract looks like. Okay, so this is cuneiform cataract. These are all the opacities, guys. I'm just coloring them in dark black colors exact for you to understand that these are the triangles or the wedges, they are the opacities. Alright, so I can see that the opacities are in the periphery, they are wedge shaped with their apex pointed towards the center. Also remember, these opacities are most common inferonasally, and there are clear spaces between the wedges. They're very easy to diagnose. Once you see them, you cannot unsee them, right? I show you, you will not be able to unsee them, you will always remember them. So let us see this image. Now, in this image, you will be able to see very fine, this is against retroillumination, right? So you will be able to see very, very small, fine, wedge-shaped, small opacities all throughout the lens. I'm just drawing some of them for you. In the periphery, you see that they have started to develop. Here there is a bright reflection, so I'm not drawing them here, alright? But the center is largely clear, and this is our cuneiform cataract. Obviously, there can be much more better images for this, but I'm showing you this image so that if you can recognize it in this image, then in easier images you will easily be able to identify it nonetheless, right? So that's all cuneiform cortical cataract. Now, some people, see, there are two ways of classifying or writing this. We now use the word cuneiform, but in the era gone by, we used to use, or still actually clinically, we use the word immature cataract. So when we are talking about cuneiform cataract, we can term it or we do term it immature senile cataract. Okay, now, if we are saying immature senile cataract has grayish color or grayish white color. All these terminologies are very important for one reason, and that one reason is when you are looking through a torchlight. Let's say you have gone into a community camp, yes? You are looking into the patient's eye with the torchlight, you don't have fancy equipments. Or you are a third year or you are an intern where your job is to screen the patients. You are looking at the lens through a torch, so you need to be aware whether it is an immature cataract or a mature cataract, yes? So when you see the lens, it will be grayish white in color. Then there is iris shadow present. What do we mean by iris shadow present? See, when I throw light, I'll just draw a cross section for you. This is my cornea, this is my iris pupil, and this is my lens. When I will throw light obliquely from the temporal side with my torchlight, the light will fall on the iris, and then the iris will cast a shadow back onto the lens. Okay, because there is a space between the iris and the lens, there is space for the shadow, yes, the reflection. When I'm throwing light on one thing, it will cast a reflection or a shadow on the back surface. So that is what iris shadow is there. Iris shadow is present. Now, if you understand cuneiform cataract, and if you understand that it is also called as immature senile cataract, if I treat it at this stage, it is okay. But if I don't treat it, then obviously it is going to progress. When it is going to progress, what is happening? What is the progression? Hydration. So what am I saying? Due to continuous hydration, lens becomes swollen. Obviously, when fluid, we keep on pumping fluid into an area, it will become swollen. When it becomes swollen, we give it a fancy name, just like we have given a fancy name to cuneiform cataract. Here we call it intumescent cataract. Intumescence. Intumescence is when cells become swollen. Yes, hydrostatic swelling of the cells, intumescence, and that is why we are calling it intumescent cataract. So it's a swollen lens. Now, in the other format of classification, we will call intumescent cataract as mature senile cataract. Mature senile cataract, when you will see, it will be white in color. Now it is no more grayish in color. It is absolutely pearly white in color. Okay, pearly white in color. There is no confusion about this. I hope that was gray white, and this is pearly white. Now, apart from the pearly white color, you will see that there is no iris shadow. No iris shadow. Why is there no iris shadow? If you were able to understand this at the top, I will explain it to you again. This is my cornea, this is my iris, but now the lens has become swollen. Because the lens has become swollen, the lens is now very, very, very close to the iris. So when I throw light onto the iris, there is no space for the iris to throw a shadow. Because now the iris and lens, because they are so near to each other, they are almost like the same surface. If they are the same surface, then there is no concept of the shadow. Shadow needs a distance to fall. Yes, shadow cannot fall if my two hands are like this. Shadow cannot fall from my in front hand to my back hand. Shadow can only fall if there is a front hand, there is a space, and then there is a back hand. I hope you understand that. That is why there is no iris shadow, because there is no space between the iris and now the swollen lens. Alright. Now, after mature senile cataract, if I don't treat it yet, it will progress further. When it progresses further, it will lead to a state which is called as hyper mature senile cataract. In hypermature senile cataract, cortex disintegrates, and it can present in any of the two variants which I am listing for you on the screen. It can present either as a very special cataract which is called as Morganian cataract, or it can present as a sclerotic calcified cataract. Let us first focus on what is Morganian cataract, the fancy name, the important name on which questions are asked, which you should be able to understand. Now, due to the continuous hydration, what has occurred? Lens has become swollen, yes. But now, when continuous hydration is occurring, more fluid is coming in. So, at last, so much of fluid has come into the cortex now that there are no cortical fibers. Fluid has completely disintegrated all the cortical fibers. So, we are saying there is complete liquefaction of cortex. Cortex is completely has been liquefied. If the cortex has been liquefied, and you think about the anatomy of the lens, nucleus is in the center of the lens. But why is the nucleus in the center of the lens? Because there are the cortical fibers supporting it in the periphery. If there are no cortical fibers, they are fluid. Will the nucleus be able to float in the center? Obviously not. The nucleus will sink down. So we say liquefaction of the cortex leads to sinking of nucleus. Liquefaction of the cortex leads to sinking of nucleus. The nucleus sinks down. Now, to understand this, let me draw a diagram for you again. This was my lens. This was my nucleus. This is what I was saying. Nucleus was present in the center because in the periphery there were cortical fibers. Now we know that the cortical fibers have been replaced by, through blue color I am trying to show you, fluid. So the cortex is completely liquefied. When the cortex is completely liquefied, water cannot hold something in the center, yes? So what is going to occur to the nucleus which was present in the center? Now because of lack of support, nucleus you will see has sunk down within the lens. I hope I'm pretty clear here, yes? So this is what Morganian cataract is. If I show you an actual photograph for this, I hope you will be able to realize this. See these photographs, see photograph A. In this, what can you see? I will draw the boundary. Can you see this yellowish colored nucleus falling down, and in the superior part, you can only see the cortex. If you want to see an advanced stage, see this, the nucleus has fallen down here, and all this is the liquefied cortex, which is not providing any support to the nucleus, and that is why the slightly yellowish denser nucleus is falling down. Or if you want to see a brilliant photograph, last end stage when the patient was completely ignorant, see this. The cortex was liquefied, and now the cortex has been absorbed. It was so liquefied, the patient ignored it for so long that now the cortex has been absorbed, and all you can see is a nucleus in the inferior part because there is no support. It is fallen within the capsule inferiorly, right? I hope you understand all the stages of a Morganian cataract. All these three are images of Morganian cataract. Brilliant way to understand Morganian cataract if you have never seen a case. These are all the variants that I can show you, and actually I have also not seen more variants than this probably. Yes. Now let us move on to the other cataract. What is the other cataract everybody that we were seeing? That was the sclerotic calcified cataract. Sclerotic calcified cataract is where the disintegrated cortex leaks through the capsule. When it leaks through the capsule, there is shrinking of lens with a wrinkled, thickened anterior capsule. Okay, and that is known as sclerotic calcified cataract because there is a thickening occurs due to calcification. There is shrinking of the lens, so we are calling it sclerotic because it has become denser or shriveled or smaller, and because it has become thickened, we are calling it calcific, and that is sclerotic calcified cataract. Alright, I hope I'm pretty clear about both of these types of cataract. The more common is a Morganian cataract in presentation rather than a sclerotic calcified cataract. It is not every day that the cortical matter is able to burst through the lens. Only when the pressure is very high, then it is able to burst through the lens, but it is very rare. Now, after we understand the stages, I hope you understand that there are three names. Number one, cuneiform cataract, number two, intuition cataract, and number three, Morganian cataract. Or there are the other three names. Number one, immature senile cataract, number two, mature senile cataract, and number three, hypermature senile cataract. Now, if I want to remember immature, mature, and hypermature, it is very easy for me to remember. In immature, there are long, wedge shape, long and tall, slim and tall. Like when you are 20, 25 years of age, like all of you are, probably you are immature right now. Yes. So you are tall and thin. Then you become mature like me, near the 40s. When you become mature, you swell up like me, you become fatter, you become obese, I can say, a lot of us at least. So immaturity is in sense. Then after 60, 65, 70 years of age, when you are hyper mature, your skin becomes loose, everything becomes disintegrated. So this is the way to remember these three stages. These are following three stages: immature, long and thin, mature, obesity, and hyper mature means wrinkled, shriveled, disintegrated. I hope we are pretty clear about this. That's how I can remember this. Now, apart from the understanding of the stages or the progression of the pathology, questions which are asked is, what is the most common complication of Morganian cataract? The most common complication of Morganian cataract is phacolytic glaucoma, whereas the most common complication of hypermature senile cataract, if they ask you just this question, then the answer will be subluxation of lens. Because when the lens is becoming smaller, shrinking, it is causing the zonules also to dysfunction. So it is becoming loose. And because it is becoming loose, it can lead to subluxation of lens. Please remember both these questions carefully. I have told you most common complication of Morganian cataract and most common complication of hypermature senile cataract. Please read these questions carefully. Now, a lot of times students think that sinking of nucleus is the same as subluxation of lens. But they have been written in opposite parts. Sinking of nucleus is causing phacolytic glaucoma, but subluxation of lens is occurring due to hypermature senile cataract, that is sclerotic. Sir, have you got wrong? No. See, that's why I'm trying to explain to you. Sinking of nucleus only means the lens is at its own place in the center. The nucleus is falling within the lens. Subluxation of lens means the lens will no more remain in the center of the eye. The lens will fall down into the vitreous. The lens will fall back into the vitreous. The lens will dislocate down, something like that. Please understand the difference between these two words. Please do not confuse yourself. Yes. Similar to these two questions, there is a third question which is asked, and that is from intumescent cataract. They ask the same question on intumescent cataract. What is the most common complication of intumescent cataract? This is something called as phacomorphic glaucoma. Now I'm just mentioning the names of these glaucoma, phacomorphic glaucoma, phacolytic glaucoma, but not explaining them to you right now. I know, sir, why are you just telling us facts? No, I'm not telling you just facts. I'm telling you facts which are important to learn here, which obviously you will get to know in glaucoma. Right now you don't understand glaucoma probably because you've not seen the video of it or not read it, but if you already know, then you know. Yes. From my side, you can see the video of glaucoma to understand what is phacolytic and phacomorphic glaucoma, so that you can learn them also. Okay, done? Now, that's all about my second type of senile cataract, and that is cortical cataract. I hope you have understood the photographs of both the stages of the cataract, that is the Morganian cataract, which I've shown you multiple photographs, and of the cuneiform cataract. After you're done with the second type of senile cataract, we move on to the third type of senile cataract. Now, the third type of senile cataract is posterior subcapsular cataract. Short form PSC, posterior subcapsular cataract. This is also known as, not very commonly, but nonetheless you should be aware of this name if it is ever used in your questionnaire, cupuliform cataract. Okay, I rarely seen clinically anybody call it cupriform cataract. We always use the word PSC only. Okay, posterior subcapsular cataract. Now, posterior subcapsular cataract. First of all, where is this cataract happening? Let us understand this. Again, I'm drawing the simple diagram: anterior capsule, posterior capsule, then in the center nucleus. So now we know this is the anterior cortex, this is the anterior capsule, and this is the posterior capsule. My question to you is pretty simple: is the red color posterior subcapsular cataract, or is the green color posterior subcapsular cataract? I know it is a very simple question, but it is for very simple knowledge. What is posterior subcapsular cataract? Red color or green color? Yes, obviously it is red color. So green color is outside the lens. Yes. So posterior subcapsular is basically a cataract or an opacity which is between the cortex and the capsule, you can say. The very minor space that is present between the cortex and the capsule, that is being occupied by the posterior subcapsular cataract. Now, if I ask you what are the clinical features of posterior subcapsular cataract, the first, the most important thing that I will like to tell you is glare. That is probably the main complaint of a patient who is coming to us with a pure posterior subcapsular cataract. That is glare. Glare basically means excessive light, diffraction of light. When you are seeing a bright light, you are not able to see because of the excessive amount of light you feel falling into the eye. How does the patient describe it? In Hindi, we call it jaun ya chamak. Yes. How do you describe glare, or how does a patient describe glare? What is the problem? Patient complains of inability to drive at night. Patient says, I can drive in the daytime, but in the night time, when light is coming from the front side on a single road, I almost go blind. I have started being fearful of driving at night so much that for the past 3 months, let's say, I've stopped driving at night altogether. Okay, I don't understand why, but I know why. I know as the doctor that the patient is experiencing fear. So that's what I'm writing. Patient complains of difficulty driving at night due to bright light. See, understand, this is not the same as nyctalopia. Nyctalopia means night blindness. Nyctalopia means the patient cannot see in night. Here I am saying the patient cannot drive at night because of the oncoming light. There is a very big difference. Alright? Now, secondly, what is the position of this cataract? See the diagram I draw. Is it central in position or is it peripheral in position? Let's say this is P is peripheral and C denotes central. So what is the position of the cataract? Central, obviously. So because it is central position, centrally located, what will it lead to? More loss of vision in daytime or in night time? Obviously, yes. So I hope you understand why I was harping on the fact that it is not more loss of vision in night time. More loss of vision will be in daytime overall. But the bright light problem, the glare problem, which is actually the main problem, will be in the night time, obviously. Then thirdly, loss of vision is more for near than far. Okay? Now, apart from these, please remember I am putting a star and writing it. Posterior subcapsular cataract causes maximum visual loss. Now, when I say maximum visual loss, what am I trying to say? When I say maximum visual loss, I am trying to say for the amount of opacity. If there is 10% opacity in the lens, nuclear cataract versus PSC, the loss of vision will be more in PSC. Why? As opacity located at nodal point of eye. So that is where our nodal point of eye is located, at the junction of the cortex and the posterior capsule. That is where this opacity is. If you remember optics, even if the nodal point is that point from where all light rays have to cross. Yes, all the light rays which are converging into the eye, they cross through the nodal point. Yes, we denote it N. All the light rays that are going inside the eye have to go through that point. That is where the opacity is. That is why the maximum visual loss compared to other cataracts is there when we are talking about the same percentage or the same amount of opacity. I hope we are pretty clear about the clinical features. I hope we understand why it is a specific case and why it is an important case. Now, once you understand this, what is the pathology? The pathology is that it occurs due to dysplasia of E cells. If we remember E cells were the equatorial epithelial cells. Yes. So when they are having dysplasia, germinative dysplasia, it leads to their posterior migration. And during migration, these cells undergo aberrant enlargement. So leads to the posterior migration and aberrant enlargement of the E cells. Now due to this posterior migration from the equator, they are migrating to the posterior capsular area in the middle. Due to their aberrant enlargement, they become large cells known as bladder or weld cells collect to form a plaque, and that plaque is the opacity. I hope we are pretty clear. So due to dysplasia of the E cells, the dysplastic E cells, they have posterior migration and aberrant enlargement. When they have aberrant enlargement, they are called as bladder cells, and bladder cells form a plaque. Okay, that is the basic pathology of your posterior subcapsular cataract. So the two things that I want to remember are the E cells, the problem of E cells, and then probably the fancy word, which can be asked to you as an MCQ, bladder cells or weld cells in the pathology. Yes, now, apart from the clinical features in the pathology, the question that is very commonly asked is, what are the causes of posterior subcapsular cataract? So the first thing I'm writing here is the use of steroids. The main important cause that I want you to remember is steroids. Okay? Steroids very commonly lead to the formation of cataract. Please remember that steroids can cause two types of ocular changes, which can be remembered through the mnemonic GTCS. Yes, grand tonic clonic seizures. What is GTCS? G for glaucoma. But glaucoma is more common with topical administration of steroids. C for cataract, what we are talking about. Cataract is more common with systemic steroids. I hope I'm pretty clear here, and there is no confusion about this. Alright. Now, apart from steroids, what are the other causes of PSC? Very important, X-rays. So when we ask you to take history in a case, we ask you to take occupational history also. That is because of this reason, right? I hope you understand. If there is a technician working in a radiology department, and he or she is not using protective equipment during taking X-rays of the patients, then over a period of time, the cumulative exposure to ionizing radiation in the form of X-rays will be high, and that can lead to the development of posterior subcapsular cataract. Similarly, you would have heard of this disease, I am sure, I'm not hoping, I'm sure, neurofibromatosis, specifically type 2, NF2. This can also lead to the development of posterior subcapsular cataract. Apart from this, you already know some of the answers. I'm just writing for you here to make it a complete list. We have already read them during metabolic cataract, myotonic dystrophy, galactosemia, blunt trauma, and we had read one more, if you remember. Which was the type of cataract which could lead to posterior subcapsular cataract? Yes, complicated cataract. Yes. Apart from these four we already know. One more cause that can lead to cataract, or I will not say one more cause actually, I will term it under the complicated cataract, is uveitis only. So in a lot of post-uveitic cases, we see cataract as a complication because it is complicated cataract. So remember the causes of complicated cataract, because in a lot of questions, uveitis or post-uveitic is also post-inflammatory, rather it is also given as an option, right? And that's all about third type of senile cataract. We have done nuclear cataract in the center, we have done in the periphery cortical cataract and posterior subcapsular cataract. Now, the fourth type of senile cataract that we have is called as anterior subcapsular cataract. Now, anterior subcapsular, if I can again draw a diagram, I know by now you understand pretty well, but still just to explain it to you, anterior subcapsular, because this is the anterior capsule, so any opacity which develops here below the anterior capsule, we are going to call it anterior subcapsular cataract. Now, this is the rarest presentation as far as senile cataract is concerned. That is why questions are also very rare. The only question that I have seen asked, or I can fathom getting asked, are the causes of anterior subcapsular cataract. The very easy way to remember anterior subcapsular cataract is 4 letters. The 4 letters I am writing: A, C, G. First of all, this is the disease. If you know, if not, then I will tell you the full form. And then after that, I write these letters again, but vertically. I write them A, C, G. So there are total 5 causes. Okay, but 5 causes remembered through 4 letters only: A, C, G. So what is A, C, G? First of all, acute, yes, angle closure glaucoma. That's the first cause. Acute angle closure glaucoma. Then A for atopic dermatitis. A for the drug immunodarone. C for chlorpromazine. and G for gold deposits. These are the five common causes listed for anterior subcapsular cataract. Apart from this, please remember that the cataract which occurs due to atopic dermatitis gets a name which is called as shield cataract. Similarly, the cataract which occurs in angle closure glaucoma gets a name called as glaucoma flecken. Fleck-shaped deposits on the anterior subcapsular area due to glaucoma fleck, and obviously we will hear this name again in the glaucoma video, right? These are the five causes, very easy way to remember. I don't think I can make it easier than this, and I hope neither can you make it easier than this to remember it. And that's all the types of acquired cataract. If I can go back to the classification, I hope you will be able to realize that when we were discussing the classification, that's what we have done. Metabolic cataract, in which we have discussed five things. Let me revise quickly. Number one, diabetes mellitus causes snowflake cataract, that is the true cataract, as well as the presenile cataract. Number two, galactosemia causes oil droplet cataract. Number three, myoclonic dystrophy causes Christmas tree cataract. Wilson's disease causes sunflower, along with it causes KF ring or Kessler pressuring, and finally parathyroid tetany, as is written in this classification also. Due to hypocalcemia can cause acquired cataract, that is subcapsular. Also, it can cause congenital lamellar cataract. In the traumatic group, the main cataract we had was blunt trauma. Blunt trauma was a rosette-shaped cataract. Then there were some others. Then in complicated cataract, we had, remember the as UMA, uveitis, myopia, angle closure glaucoma, and retinitis pigmentosa, causing a breadcrumb appearance with polychromatic luster. And finally, in senile cataract, we have read four types of cataract. Let me quickly just note them down for you here. Nuclear cataract, which is central in position, causes more loss of vision in the daytime. The color is yellow, xanthopsia, and Eurochrome pigment, and due to sclerosis, it causes index myopia and second sight phenomena. Then cortical cataract. Cortical cataract is in the periphery, so causes more loss of vision in the nighttime, three stages: immature, mature, or hypermature. Immature is cuneiform, mature is intumescent, and finally hypermature was either Morganian or sclerotic calcified cataract. Then posterior subcapsular cataract, where we had read about the word glare, we had read about the fact that it causes maximum visual loss and the specific word bladder cells or Weld cells, and finally the rarest cause, that is anterior subcapsular cataract. And that is all about your acquired cataract and its good revision. So when we start to discuss the steps of phacoemulsification, then before we move on to the operative steps or the surgical steps, we want to understand how to prepare a patient for surgery or the pre-operative steps, right? When you're thinking about doing cataract surgery, phacoemulsification or any other cataract surgery, obviously, what are the things you need to keep in mind? Number one, you need to keep in mind that you need to dilate the pupil. If you have not dilated the pupil is constricted, your view of the lens is very small, you can only see a very small central 3 mm of the lens, obviously surgery will not be possible to that. Okay, so how do you dilate the pupil? Pupil is usually dilated with the help of tropicamide plus phenylephrine eye drops. Okay, that's the main thing. If you want a longer dilatation, which is usually not needed, you can use formamide eye drop, that is formamide tropinose and benzoate eye drops. Secondly, what else do you want to do? You want to be able to have a anesthetized eye, yes. So along with dilatation of the pupil, you want to give anesthesia. Obviously, it has to be local anesthesia. We are not interested in general anesthesia. Now, this local anesthesia can be given or is mostly given topical. Topical means eye drops. So proparacaine eye drops are given. Anesthesia can also be given intracameral. When you are giving topical anesthesia, sometimes you need to augment it with intracameral. So you can give an intracameral injection of lignocaine. So basically, both of them are used together, if I can say so. Then, obviously, what you can do peribulbar anesthesia, or what you can do retrobulbar anesthesia. If you're not aware of these names, please go and watch the video, the starting videos on the basic anatomy of the eye, where I discussed all the routes of ocular drug administration, under which I explained you what is peribulbar and retrobulbar. Peribulbar means around the eye, and retrobulbar means behind the eye. As we know, retrobulbar is not preferred. What is preferred is peribulbar anesthesia, which is also called as a peribulbar block. What is used under peribulbar block, if that is the question? How or which drug is used? It is a combination of drug. For long duration of action, we are using bupivacaine. For quick onset, we are using lignocaine. Then, along with that, to make it more quick, we are using 1:2 lakh dilution of adrenaline mixed. And along with that, for better breakage through muscular tissue and all the dietary tissue, we are also adding hyaluronidase. So this is what makes our peribulbar block or peribulbar anesthesia, sometimes also called as mitricaine. Okay, I hope I'm pretty clear about this. There is no confusion about this. Yes. So number one, we are dilating the pupil. Number two, we are giving anesthesia. Then, apart from anesthesia and dilatation of the pupil, what do we need to do? We need to sterilize. Okay. How are we sterilizing? Obviously, we are giving pre-operative antibiotics, pre-operative topical antibiotics. Usually they should be given, but because it's a very quick surgery, a lot of times if we are doing the surgery on the same day, we do not give it also. Alright. And what is the universal prophylaxis as far as sterilization is concerned? What is the universal prophylaxis, guys? Not only about the eye surgery, about everywhere. Yes, obviously the use of 5% povidone iodine or betadine solution instilled into, where are you going to instill it if we are doing the surgery of the eye? Yes, we instill it in the conjunctival sac. Okay, we are going to instill it in the conjunctival sac for at least 1 minute prior to the surgery. Apart from that, the usual painting where we are cleaning the appendages around the area to be, operated on, all that is obvious, very obvious, and all that is also done. But these are the three main things which we are doing pre-operatively now. Once you have prepared the patient is in the operation theatre, now you need to start the surgery. So now you need to know the interoperative steps. So before I go on writing about the interoperative steps, let us watch a video of photoemulsification so that we get a hang of all these steps better, right? Surgeries you've seen, they seem easier to understand. So at the beginning of this video, let us first see a very important point, guys. We see that the whole pupil is dilated. Yes? Why is it dilated? As I've already explained, that to have a field of view, everybody, as well as the field of surgery. We want to take out the lens, everybody. The lens is behind the pupil. Now as the first step, you can see that an MVR blade, everybody, is creating an incision, clear corneal incision, right? And you will see that this surgeon prefers to create two side ports or side incisions, so he's creating another side port or side incision. That's our step one. It helps us to inject viscoelastic, as we see. What is a viscoelastic, guys? See, there is aqueous in the anterior chamber. That is a fluid that will keep leaking out. So we need our anterior chamber to be stable. So to stabilize the anterior chamber, we have to fill it with a more dense material, and that material is viscoelastic. So it gives us a stable field of suction.
Now, after the anterior chamber is filled with viscoelastic, this surgeon tends to perform step 4 before step 2 and step 3. These are all surgeon preferences. You can see a 2.2 mm keratome being used. Yes, now see it everybody. So the keratome is creating a biplanar incision. First it is going in the cornea, then it is going down to create an incision. Now this surgeon prefers to do step 2 and step 3 later on, but those steps are done through the side put. You will be able to see a 26 gauge bent needle creating flap, everybody, you can see now, you can see a beautiful flap has been created in the anterior capsule. The anterior capsule has to be cut, everybody, yes, to be able to touch or remove the nucleus and the cortex. So you see that the surgeon is creating a circular window, everybody. You will see, he is completing, you can see the margin of the circle here, everybody. You can see the margin of the circle here, everybody. Now the surgeon is coming closely, and the surgeon is completing this step. This step is known as CCC, continuous curvilinear capsulorhexis, guys. Now the capsulorhexis has been complete. You will be able to see a complete round circle, everybody. See, everybody, you will be able to see a complete round circle going here, coming here, everybody. You are able to see a complete round circle. Now, this surgeon preference to do it without staining the anterior capsule. As we discussed in the theory, that some surgeons can stain this anterior capsule with a trypan blue dye. Through that, we are able to see a blue surface, and it becomes slightly easier to be able to perform this step. This surgeon is an experienced surgeon. He is able to perform this step against the red glow of the fundus. This orangish or reddish glow that you see, everybody, this is the fundal red reflex which is showing through. Now, you see we have taken a cannula and we have gone below the anterior capsule, injected fluid such that there is hydrodissection. Hydrodissection is what, everybody? Hydrodissection is separation of the cortex from the capsule. And that is why you will be able to see that now we are able to rotate or move the nucleus within the capsular bag or the capsule, everybody. Because now it is free from attachments of the capsule, and now I have free rotation of the nucleus. Now you will see, everybody, that the surgeon inserts a probe, a pen-like structure. See at the bottom of your screen, inside. This is called the phaco probe, everybody. Yes? Through this phaco probe, he will try to remove this nucleus. This phaco probe has 3 functions. The first, it can irrigate. See, when we are sucking in something out, we have to keep on replacing fluid, everybody. Irrigation. It can aspirate, it can suck, and it has energy. Phacoemulsification, ultrasound energy. You will see the ultrasound energy in action in a while, everybody. Let us see. See now. Now you see that the surgeon is using ultrasonic energy and is creating a groove, everybody. Can you see? It is looking as if there is a cake and I am eating that cake. Okay? What is this energy? Ultrasonic. But this ultrasonic energy basically does what? At the tip of the probe, it converts it into to and fro motions. So basically we are chiseling, everybody. Through chiseling, we eat up the material. Now you will see nuclear fragmentation. Everybody, let's see. The surgeon will soon be able to divide the nucleus into small pieces. Everybody, let's see. Yes. See, now you will be able to see a break. You saw a small break, now you'll be able to see a complete break. The surgeon again attempts to break the nucleus into small pieces. And at this point of time, yes, see, now you see a complete break, everybody. You see here, a complete break has taken place. Now, more such breaks are created. Another break has been created. Another break has been created. So, more such breaks are created to form smaller nuclear fragments so that it becomes easier to suck them. We can't suck the whole nucleus together, everybody. So, now you see that the broken pieces, again breaking pieces, and now the surgeon is sucking them in the phaco probe through the aspiration of the vacuum action, I can say. Small piece sucked in. Again, you will see small piece sucked in, everybody. Yes? Keep on seeing this, everybody. So this is basically called phacoemulsification. The word phacoemulsification comes from here, that using the ultrasonic power, converting it into to and fro motion, we are doing emulsification. We are emulsifying the small fragments of the lens, and we are sucking all the lens particle through our phaco probe. Now you can see that almost all the nucleus has been removed. What remains here, everybody? You can see some cortical fibers in the periphery. You can see, everybody, some cortical fibers which have been loosened by hydrodissection, but they have not been completely removed. Now we take another instrument which looks like the phaco probe. Everybody will be able to see this instrument here. It looks like the phaco probe, but it is actually called the INA, irrigation and aspiration. That means it is doing just 2 functions instead of 3 functions. It is irrigating, fluid obviously needs to be continuously replaced, and it is aspirating, it is sucking in these cortical fibers. Cortical fibers, if you remember, are soft always. Nucleus is hard. Nucleus is large and hard, so we need to break it and emulsify it. Cortex is small, so we can just suck it at very soft and small pieces. We can just aspirate or suck them. Now you will see that gradually all 360 degree, the surgeon will move the I and A, everybody, irrigation and aspiration, and you'll be able to suck all the cortical material. Now you can see going here, everybody, sucking in, coming here, sucking all the cortical fibers. You can see them peeling out easily because they have been hydro-dissected. Had they been stuck, everybody, the posterior capsule would also have come in. Now that the cortical fibers have been cleaned up, everybody, you can better see against the red glow the margins of the anterior capsule. See, everybody, you can see a beautiful anterior capsule, capsulorhexis, everybody. See, continuous curvilinear capsulorhexis. Okay. Now you see that the surgeon is injecting the lens IOL through a small 2.2 mm incision, but the diameter of the lens is 6 mm. Why is it possible? Because this lens is foldable. You could see it was folded and now it is slowly unfolding, everybody. Yes, it is slowly unfolding, everybody. And now you will be able to see that the surgeon is pressing it down below the anterior capsule and rotating it, everybody, to see whether it has been completely able to get everybody inside the capsular bag. And once we are able to implant the IOL in the capsular bag, we say our surgery has gone to be successful. The only step which remains is the small incisions we have created, we want to close them, but we do not suture them, guys. We just close them by hydroclosure. So we hydrate those, so there is slight edema leads to closure. Because our incisions are small, 1 mm and 2.2 mm only.
Okay, so now everybody that we have seen the beautiful video of phacoemulsification, I hope you have watched it at least twice to be able to understand it. Let us write the intraoperative steps. We have prepared the patient, we have operated on the patient. I hope a lot of words that I will be writing here have already spoken, you've already understood, but let us still write, okay? So overall, if we are talking about step 1, step 1 is, as you saw in the video, create a side port incision. We call it a side port, okay? Because it's a small incision, usually around 1 mm or less than that in size. Side port incision using a 15-degree blade. That's what it is called as 15-degree blade. And as you will be able to see in the image, this is what a 15-degree blade looks like. You can see the cutting edge. The cutting edge is at an angle of 15 degrees. If we see the straight edge, and along with that, if you see the cutting edge, the angle would be around 15 degrees or is exactly 15 degrees, and that is why it is called as the 15-degree blade. Or another blade can be used, which is called as an MVR blade. MVR blade is a triangular, very small triangular blade with 2 cutting edges. But the basic size of incision created is almost the same. It is on the surgeon's preference whether they are using a 15-degree blade or an MVR blade. I prefer to use the 15-degree blade. Alright, now, through this side port incision, through the step 1 of the side port incision, that's what I'm saying, side port. Why are we creating this side port incision? If you understood the video, we are creating the side port incision because we need to stain the anterior capsule, yes. So the first step we are doing through the side port incision is we stain anterior capsule of lens using Trypan blue dye, which is again a surgeon's preference, as you would have seen in the video. See, obviously all these steps are not mandatory. Over the years, surgeons keep on, inventing their own comfort, right? So a lot of times we don't stain it. A lot of times we do stain it. Some surgeons stain it, some surgeons don't stain it. But theoretically, these are all important steps which you need to do ideally when you are starting out, at least when you don't have your own set pattern before you have done probably 1,000 surgeries, you are here for all these things, okay? So Trypan blue dye is used to stain the anterior capsule of lens. Why? Because all the structures of the lens are transparent. That is why we need to stain the anterior capsule to see the plane. So now if you see this image, don't focus on the center part, focus that the capsule is stained. Capsule stained with blue color dye. Yes? Now why are we staining the capsule with blue color dye as we see on the photograph? Because we need to open the anterior capsule to access the internal structures. Yes? That is the basic thing we understand. We are not removing the capsule, but we want that there is a small area of access. Yes? So we want to open a window, and that is called as CCC. What is CCC? What is CCC? Very good. Please keep on saying. You just now heard all these words. Continuous
Curvilinear capsulorhexis.
Curvilinear
Capsulorhexis.
capsulorhexis. Rhexis means to break. Okay? So continuous curvilinear capsulorhexis. That is what we are doing. A round window is being created in the anterior capsule. As you can see, this is the last point, end point of that, okay? So we have created a round window, continuous curvilinear capsulorhexis. I will say a hole in anterior capsule or an opening in anterior capsule. Okay, this is the preferred technique. But remember, there is another way to do this. Another way to do it is called as opener technique. If you've ever opened a can with the can opener, though even though it's an instrument of the past, it used to cut the can like this, zigzag. Okay? This is how the can is opened. Through small radial cuts connected with each other. So if we don't know how to do CCC, initially actually when I was taught can opener technique. And then the can opener technique has some pitfalls or drawbacks, and that is why the better way is CCC, and that is when that is how the teaching during our era was. First of all, we were taught can opener, and then we were made to progress on to the CCC. Alright, CCC is slightly difficult to learn, that is what is called, but once you learn it is very easy. Now, what is the problem with can opener technique? The problem with can opener technique is it can lead to radial tears. See, because there are so many edge points. Can you see there are so many edge points? When I'm doing any maneuver, one of these edge points may completely tear up. So the capsule may completely tear up. That is why CCC is not preferred. Number two, multiple cuts lead to a zigzag, unstable lens. Zigzag incisions lead to an unstable lens. The lens does not completely fixate, and the lens can keep on moving up and down. So these are the problems with a can opener technique. That is why what do we prefer, everybody? We prefer CCC, continuous curvilinear capsulopraxis. Also, CCC decreases the chances of a complication which is called as PCO. Remember this, when we discuss PCO, you will understand this, okay? So basically there are three advantages of CCC, that it resists the radial tears, or it makes the lens stable, and it decreases the chances of PCO, or the other way around. These are the three disadvantages of a can opener technique. Alright. Now we have created a hole inside the anterior. Now we can see the internal structures, that is the cortex and the nucleus. That means now we move on to our main step, or step 2, I can say. What is my step 2? My step 2 is to create the main port incision. Main port incision is done or created using usually 2.2 millimeter keratome. The instrument is called as a keratome. The size of the keratome can be different, 2.2, 2.4, 2.8 or 3.2 mm depending upon the surgeon's preference. What I use is a 2.2 mm keratome, usually, or sometimes lesser than that, which have come into effect with the advancement of the surgeries. So if you can see the images, these are the keratomes. This is the image. This is the keratome, a V-shaped blade with two cutting edges, and we are going inside the cornea. This is the cutting edge, and this is what the instrument looks like. This is called as a keratome, creating the main port incision. Through the main port incision, the first step we are going to do, I am writing A again. Step 2, through the main port, the first thing we are going to do, you have seen in the video, you are seeing it here again, I am writing the name, is called as hydrodissection. Now what is hydrodissection? You already understand, let us just name it hydro. Hydro means fluid, dissection means to separate. So we are separating cortex from capsule. That's the main key. We are separating the cortex from the capsule by injecting a jet of fluid just below the margin of anterior capsule. Okay? So first of all, let us see the actual photograph. We have taken a 25 gauge cannula, and through that cannula we have just gone below the upper margin of the anterior capsule, and we are injecting fluid. What is this fluid going to do? As you can see, this fluid is going to go below the anterior capsule, strike the equator, and then move posteriorly towards the center, thus separating the anterior capsule as well as the posterior capsule from the cortex. Why are we doing this? Because we do not want to remove the capsule. Because we do not want to remove the capsule, we want to separate the cortex from the capsule, so that when we remove the cortex, the capsule does not get pulled along with it. Yes, I hope you understand this. This is a very important step. Okay? Now, after hydrodissection, what can be done? Hydrodelineation. This is not a step which is done by everybody, but this is almost like a elective step. Hydrodelineation is separation of epinucleus from endonucleus by a jet of fluid or water again. Okay. So especially in cases of nuclear cataract, because we have zones of nucleus. I hope you remember the zones of nucleus. So we say the central will be the hardest and the peripheral will be the softest. So if we can inject some fluid between these zones, So we separate out layers. So now we will have a cortical layer, we will have an epinuclear layer, and we will have an endonuclear layer. What is the advantage? We know the cortex and the epinucleus are softer compared to the endonucleus. So we can probably just suck the cortex and the epinucleus, but we need to apply power to break the endonucleus. So it becomes easier to remove each part based on its consistency, softness or hardness. And that is why I am saying it is an elective step, it is not necessary. Alright. Now, once we have been able to separate all these parts by hydrodissection and hydrodelineation, okay, then what is that we need to do? We need to do now the third step, that is nuclear fragmentation. As we saw in the video, nuclear fragmentation is done with the help of the with PecoPro. That's what we call it, PecoPro. Okay. Now, what does this PecoPro do? This PecoPro has a, you've already seen all this. This PecoPro has a piezoelectric crystal in its tip. What does this piezoelectric crystal do? It converts ultrasonic energy into mechanical to and fro motions. Into mechanical to and fro motions. So if you ask me how does phacoemulsification work, this is how phacoemulsification works. The ultrasonic energy is coming in and that is being converted into this kind of movement, okay? When we are breaking a rock, this is what we do, chisel and hammer, yes? So this is what my PecoProbe is doing, it is doing this. It is by this to and fro motion movement, it is moving ahead slowly, and it is breaking. Obviously, in real life you will see it, with the advancement of technology, it seems very fast. But it is actually, if you slow it down, it is this movement, okay? So this is to and fro movement, which is small, slowly breaking the nucleus into small parts, nuclear fragmentation. After nuclear fragmentation has been done, what are we doing? We are doing irrigation and aspiration. Irrigation and aspiration. That means now we have two arms. One is giving fluid in and the other one is sucking out. Through irrigation and aspiration, we are removing nuclear fragments and cortical matter. Once we have removed the whole nuclear fragments, once we have removed the cortical matter, what we are left with? We are left with an empty capsular bag, and now we are going to implant an IOL, or called as intraocular lens. Okay, so we are going to implant an intraocular lens or IOL, and that's all about the steps of the surgery. I hope you understand the name CCC. Please remember hydro dissection, hydrodelineation, all these words are important. Overall, try to understand how the surgery is done. Rewatch the video if you are confused at all. Alright, these are the steps of the surgery, but now, before we move on, we have a word called IOL. So now let's understand about the IOLs, intraocular lenses. Okay, before intraocular lenses, understand, I told you the name of the surgery was FLACS. And I told you FLACS was similar to phacoemulsification. Yes. How is it similar? Let me show you a photograph. In this photograph, if you see, we are using laser to do two steps. What are the two steps we are doing laser to do? It is creating, you will be able to see if you see carefully. Can you see through the laser? We have first aimed the laser in this image, and through the laser, we have created an opening in the anterior capsule. That means FLACS uses laser for CCC. Yes, that's the main thing, because that is something which can go wrong. Okay. Secondly, you will see there is no area from where I am creating a main port incision. So it creates a main port incision. These are the two jobs which are being done by FLACS. Apart from that, the surgery is absolutely similar. Then what else it can do? Now, can you see these lines? 1, 2, 3. What they are doing nuclear fragmentation. Okay, so created the CCC, created the main port incision, and created some fine lines as chalk or as parts to fragment the nucleus. So it becomes easier. You don't need to now do the to and fro motions of the phacoemulsification, and that is why it is a laser-based surgery. Okay, I hope we understand FLACS, the steps are the same, but some of the steps are being done by a laser. Obviously, you are handling the laser at large, it's not a robotic surgery. So please don't say robotic, please, in layman's language, a lot of patients come to us and say, sir, robotic surgery it is. And we say, no, it's not a robotic surgery. Robotic surgery means that I can handle it sitting here, I can do the surgery, I can't. I have to be there in the OT, I have to operate the machine, I have to position the machine, I have to be careful that all the planes are correct, and then only it is possible. FLACS. Now, the most difficult step is, if you realize, for the surgeon is CCC. I'll show you an example. This sign. This is the Argentina flag. And that is why this is known as the Argentinian flag sign. This is especially seen in cases of intumescent cataract. If you remember, in intumescent cataract, the pressure, the swelling of the lens is there, so the pressure, intralenticular pressure is high. Due to high intralenticular pressure, as soon as we start doing CCC, we create an incision here. We want to turn it around, but because of the pressure, if there is too much of pressure, as soon as you give it a nick, the whole packet will burst. It bursts vertically or radially, we say. It gives a radial tear. And it appears like a blue area, a white area, and a blue area. White colored intumescent cataract is white color, and that is why it is called as Argentinian flag sign. Just remember, this is a specific complication which can occur even with the best surgeons in cases of intumescent cataract. All right, guys. Now, once you know this, now let us move on to the types of intraocular lens or IOL. IOL. The first question that comes into my mind is about intraocular lens. What are the sites of implantation of IOL? We know that the best site is in the capsular bag. But if I can tell you, there are some other sites also. So let us look at this diagram on the screen. If I draw this line diagram, this is what my eye would look like when I have done the surgery, or when I am doing the surgery rather. Yes? This is my cornea, this is my iris, this is my anterior capsule with the CCC, and this is my posterior capsule. Yes? Now, there are three places where I can implant the intraocular lens. First of all, obviously, yes, this is the place. But what do we call this? This is called in the capsular bag. Because we have left the capsule, yes, that is why we have left the capsule. That's what I'm trying to explain you since the beginning, the difference between ICC and ECC in the capsular bag. But what if the capsular bag is damaged? See, there can be complications which we will discuss next. The complications of cataract surgery. If there is any complication of cataract surgery due to which the capsular bag is damaged, we won't be able to implant it into the capsular bag. So where else can we implant it? In that case, we can implant it here in the space between the anterior capsule and the iris, or what we call as the posterior chamber. But when we implant the lens, this is called in the sulcus. Both these lenses, because they are behind the iris, these positions are called as PCIOL, posterior chamber intraocular lens. Okay, but what if I have a novice? Novice means a new person. When I was new, I was a novice. Similarly, you will be one. Novice is usually whenever they get complicated surgery, you will find implant an IOL here. This is the easiest to implant. Where have I implanted the IOL? I have implanted the IOL, I will say number one. Where have I implanted the number one IOL? I have implanted the number one IOL in front of the iris. That means number one IOL is anterior chamber intraocular lens, ACIOL. That means I have three positions to implant an IOL. ACIOL, anterior chamber, or two PCIOL, in the sulcus, in the capsular bag. Always the best site of implantation is in the capsular bag. From where we have removed the capsule, the cortex and the nucleus, that is where we are implanting the intraocular lens. There is no confusion in this. But now we know there are two types of IOL, ACIOL and PCIOL. PCIOL can be of two types. One is called as rigid PCIOL, and one is called as foldable PCIOL. From the name itself, you understand rigid means something which cannot be made smaller by folding, which is rigid. ACIOL and rigid PCIOL, both are made of polymethyl methacrylate, PMMA. So ACIOL and rigid PCIOL, if I need to implant it, I cannot implant it through an incision of 2.2 mm. I can implant it through a larger incision. So basically when ECC and SICS was done, then we used to implant rigid PCIOL. But in phacoemulsification and FLACS, we implant a foldable PCIOL. If we have a complication where foldable cannot be implanted, then we need to make the incision larger again, up to around 7 mm in size, and then only we can implant an ACIOL or a rigid PCIOL. Now, foldable PCIOL is made of mostly acrylic. Okay. If you see the brand names, if you have got a surgery done in your family, you will see the brand names like Acrysoft, Acryol. So all the brand names usually use the word somewhere acrylic. They are trying to come up with the acronyms of acrylic. Or it can even be made up of silicone. Silicone. Silicone IOLs are preferred if patient has or needs a vitreal surgery. Okay, you will understand this because in a lot of retinal surgeries we will put a silicone oil in the vitreous cavity. That is why a silicone IOL is preferred there, whereas in all other cases acrylic IOL is preferred. Okay, these IOLs are usually hydrophobic. Acrylic IOLs are usually hydrophobic, so that the aqueous, they don't get stuck to the aqueous, or the aqueous does not get stuck on them. That are acrylic IOLs, foldable IOLs. All right, I will show you two images. Now, when I show you these two images, how do you know which one is it? So that the aqueous, they don't get stuck to the aqueous, or the aqueous does not get stuck on them. That are acrylic IOLs, foldable IOLs. All right, I will show you two images. Now, when I show you these two images, how do you know which one is ACIOL and which one is PCIOL? By common sense, obviously. I had written ACIOL on the left side, so this is ACIOL. I had written PCIOL on the right side, so this is PCIOL. But apart from that, how do you recognize? This area, the central area, this is called the optic area. Optic means which will come behind the pupil, from where you will have all the vision. And this part, these parts are called as haptics. Okay, optics and haptics. Haptics are what differentiate ACIOL from PCIOL. In ACIOL, if you carefully see, I have S-shaped haptics. But if I see a PCIOL, I have C-shaped haptics. Okay, see, this will be a C, or if I can say this will be a C, a straight C or an opposite C. This is an S, this is an S. Okay, so an S-shaped haptic or a C-shaped haptic, that is how we can differentiate when we are looking at an image, whether an ACIOL has been implanted or PCIOL, or if it is given to us, we can identify both ways. Now, I hope we are clear about the types of IOL, where to implant them, what are the materials, everything. There are some special types of IOL, like this IOL. This is called as a multifocal IOL. Normally the IOLs, we are talking about the images that we have just seen, they have power only for distance. See, our crystalline lens, the natural lens that we have, can look at a far object, and due to accommodation, but due to the change of the curvature, it can also see at a near object. But when we are talking about an acrylic lens, an artificial lens, it cannot accommodate, it cannot change its curvature. So it is only a monofocal lens. It can only give you vision for far. For near, you have to wear a spectacle. Though that is not a problem. But what if the patient wants not to wear spectacles at all? Can we make the patient spectacle free after surgery? Yes. We have to implant multifocal IOLs. Multifocal IOLs have multiple rings. Okay, can you see? Each ring has a step ladder. The central part will have vision for the nearest object, and as we go along, it will keep on increasing the power for distance objects. Okay, but it has the side effect of glare and halos. Due to these multiple rings of multiple power, a lot of time patients report seeing these halos or these rings when they are looking in bright light, or they experience diffractive vision. Okay, and that are the side effects. The use is obviously better than the side effects. It depends upon the profession. If the patient is a truck driver, if the patient drives too much at night, then I will not be giving this to the patient. But if I see that the patient is a housewife, let's say, or a homemaker, then I will be inclined to implant this IOL. Similarly, if you know, there are two types of powers of the spectacles that you have, spherical and cylindrical. If you have cylindrical power, then you need to get implanted toric IOL. Toric IOL is used to correct cylindrical power, or what is known as astigmatism. Okay, so see, we are talking about all these IOLs just because with advancement of technology, with advancement of disposable income in India, patients want the best possible. The patients say, if I'm doing cataract surgery, if I'm getting cataract surgery done, why not remove my pre-existing glasses also? So if the patient had a pre-existing astigmatism, then I can implant a toric IOL and remove that also. Similarly, the design of the IOL that is manufactured these days more often than not is called as a square-edged IOL. And the benefit of square-edged IOL, see, one is this and one is slightly this. I hope you understand, okay? That, or how do I draw it for you? That even though it is a circle, but it is slightly squared out edges like this, okay? The edges are slightly squared out, okay? Square-edged IOL. It reduces chances of PCO, which is called as posterior capsular opacification. It is a very common complication of cataract surgery. Posterior capsular opacification. And these are some of the important types of IOL which you need to know. I hope you've been able to understand. But before we move on to the complications, the question that is coming into my mind again and again, which I hope some of you ask yourself is, why are we implanting this IOL? Why are we implanting an IOL? What is the need for the IOL? Yes, Yes, very good. We are implanting an IOL to replace the power. Yes, lens had a power of plus 16 diopter to plus 19 diopter. That is what I want to replace. When I want to replace that power, what do I do? What do I do? Tell me. I put an artificial lens. When I put an artificial lens, the artificial lens has power. But is the power universal? Is my power? I am in normal eyes. I have no power, normal eyes. I mean to say, I don't have any need for spectacles. My far vision is also normal. My near vision is also normal. Versus a lot of you who are wearing glasses. You are wearing glasses or spectacles because your power of the eye is not normal. Your vision is not clear. That is why you have to wear a -3, +1, +2, whatever to make your power normal. That means when I'm replacing the lens in my eye versus an eye which is wearing spectacle, the power of IOL needed will be different. Yes? So, a prerequisite before surgery, always in every case, is that we should calculate IOL power. Calculation of IOL power is biometry. That means we are saying before surgery, biometry needs to be done. If we don't do biometry, then we will remove the cataract. But in almost all the cases post-surgery, we will see that they will have a refractory error. So that is not the problem, yes. But again, as I said, with disposable incomes, that is not what the patient wants. Patient wants complete satisfaction. So biometry is a prerequisite. Now, biometry comprises of 3 steps. Step 1. In step 1, we measure corneal curvature. In step 1, we are measuring the corneal curvature. Corneal curvature is measured by an investigation called as keratometry. Yes. As I told you in the basic anatomy video, everybody, kera means cornea, always remember that. So when we are talking about anything kera, we are talking about cornea. But the question which is coming into my mind is, why am I doing corneal curvature? Why am I measuring something about the cornea when I am calculating the power of the IOL? See, again, the answer is in the fact that I want to remove your spectacles. I want to make you absolutely normal. I know power is present in the eye lens, in the eye, in the lens, and in the cornea. So when I am trying to replace your lens, I am also trying to accommodate or manage the power of the cornea. Yes or no? Yes. If the corneal power is more or the corneal power is less, I will be able to manage that also into the power of the IOL. My ultimate aim will be not to give you any pair of glasses. Now, the power of cornea depends on its curvature. How round is the lens? Yes or no? That's what we discussed. So how round is the cornea gives its power. That's why we are measuring corneal curvature. In step 2, we need to measure the axial length of eye. Now again, I hope you know what is axial length. Again, I have spoken this word earlier in my basic anatomy video. If you've forgotten this, I am again writing. Axial length means antero-posterior diameter. Antero-posterior diameter of eye, AP diameter. What is the normal axial length of eye? 24 millimeters. Yes, 2.4 centimeter to 24 millimeters. Again, all these facts we have spoken in the basic anatomy video. This is just for your note completion and for your revision, you can say here. Now, how do we measure the axial length of the eye? Anybody? Radiology? Radiology? Does it click? Yes, obviously it clicks. So, we measure it through A-scan ultrasonography. A-scan ultrasonography. That is how we measure the axial length of the eye. What is A-scan ultrasonography? If you remember, ultrasonography is of 3 types: A-scan, B-scan, and M-scan. The full form of A-scan is amplitude scan. In amplitude scan ultrasonography, 8 megahertz sound waves, ultrasound works on sound waves, yes? 8 megahertz sound waves are projected inside the eye. Then whenever they strike each structure, echoes are received. When we receive echoes, those echoes are converted into a graph like this. See? So when I'm firing the sound waves, the first echo I'm getting is from the probe itself or from my ultrasound point. Then it is striking the cornea, so I'm getting an anterior corneal peak, a posterior corneal peak. Then I'm getting an anterior and posterior lens peak. Then I'm getting a retina peak and a sclera peak. I hope you can see all these peaks. Yes? So when I need to measure the axial length, I measure it from the anterior corneal to the retinal, and I basically get the axial length of the eye. I hope we are pretty clear about this. Yes, we are measuring the distance between the spikes to measure the axial length of the eye. And this is my A-scan ultrasonography. Okay, done? Are we clear about this? Now, once we have got these two values, we put them in step 3. Okay, what is step 3? We put them in a formula. The most commonly used formula that we have is called as SRK-T formula. Sanders, Retzval, Kaufman or Kraft formula. Okay, SRK-T formula. This is the most commonly used. I'm not going into the details of what this formula is. All these are machine-based investigations, as you will be able to see in the video. Yes, you don't need to remember these formulas at all. Then Holiday formula, offer Q formula. Holiday is specifically used if axial length is greater than 24.5 mm, it gives better results. And offer Q is used if axial length is less than 22 mm. So majority of the cases we see the axial length lying between this range only, okay? But if it is too high or too less, then we say that we have to use specific formulas. Similarly, there is a formula which is called a third generation formula or the Agis L formula. Agis L formula is specifically used in post-LASIK cases. Post-LASIK cases means after you have gotten done surgery for refractory errors, okay, then your corneal curvature is changed. As corneal curvature is changed. So because corneal curvature is changed, your step 1 values are not entirely correct. And that is why the normal formulas that we use, they will give you the wrong IOL power. So we need a special IOL formula that is called as the Agis L formula. Please remember such stuff.
Hello everyone, this is a video on how to do biometry. All of us are already aware that biometry comprises of 3 steps. Number 1, keratometry, which is not being shown here. What is being shown here is the second procedure, how to measure the axial length via A-scan ultrasonography. So this console that you can see, this is an A-scan console. We will focus on it later again. And out of the A-scan console is coming out a probe like this, which you can see in my hand. So A-scan or biometry, we can say is of 2 types. Ultrasonic biometry, number 1, and number 2, optical biometry. What I have in my hand is an ultrasound biometer. This is an ultrasound probe, which if I press the button on the machine, you will be able to see the ultrasound light ray coming out now. Alright. Either we can, if this is the cornea, we can touch the cornea of the patient. This is called as contact biometry. Or we can place this probe into a plastic chamber, which as you can see is connected to a syringe filled with fluid. That means when I am touching the patient's cornea, I am actually not touching the probe. I have fluid between the cornea and the probe. That is what we are going to see, immersion method of A-scan in a patient. So now as you can see, the patient is in supine position. We have the immersion chamber along with the probe of A-scan in our hand. We ask the patient to open the eye. We gently keep the cap of the immersion chamber onto the patient's eye. Now we ask the patient to look in the red eye. Side red light में देखो. Yes. Now we inject fluid to fill the chamber. Side light में देखो, side लाल light में देखो. Now as soon as we do that, if we can look at the screen starts showing us spikes, and also we can see recordings coming on the screen. Now once the recordings have been done, we gently remove the immersion chamber, we clean the patient's eye, and now we can look at the screen. Screen has given us 10 values and then the average of each value. If we can see the TL, which is showing us the axial length, we see all the axial lengths are almost similar with a very small variation between the readings of maximum up to 0.09. Alright? We can see the spikes, the spike coming from the probe, first from the cornea, then from the retina, then from the sclera. This yellow line, this is the line of threshold. The retinal spike that we get should be higher than this. If I can show you all the readings, you will see the retinal spikes are higher than all of this. That tells us that we have done a correct A-scan, and that is how the machine measures the axial length. You will be able to see the average has been shown to be 22.39. 22.39 mm, that is the axial length in this current patient in the left eye. We have done it on OS. OS is the left eye. And that is a small demonstration on how to do ultrasonic A-scan without touching the cornea of the patient under immersion method. What is the disadvantage of a contact method? When we are doing a contact method, as I showed you, we are touching the cornea directly. That means it depends on the force of our hand. If we apply too much of force, then we are indenting the cornea. When we are indenting the cornea, we are shortening the axial length. And when we do immersion A-scan, that is what we avoid. In immersion A-scan, we are not putting pressure because there is a fluid level between the cornea and the tip of the A-scan probe, as you just now saw in the patient. And that is why either optical biometry is preferred or ultrasonic immersion method of biometry is preferred in a patient to calculate the axial length of the eye.
Please remember that biometry is one very important technique that all of you should know, and interns actually. Interns should know how to do this. If not know how to do this, they should have at least seen. I hope if you are still an intern or if you are still to do your internship, you realize the value of seeing clinical techniques, right? A lot of time we think that if we spend time reading and doing MCQs, we are better off. Yes, you are better off probably if you mug up. But if you've seen those techniques, then you never forget them, right? Seeing is better than reading. So if you go to your internship postings, if you try to see or ask questions a little bit, probably you will learn the more clinical stuff. That is all what I always say. This is the paradox. We are all going to become clinicians, but we are afraid of clinical questions. That's what we said. Now the exam is going to become more clinical. So it is good now. We are clinicians. The exam is to be clinical, but we are afraid of that because we always spend 5.5 years in theory. Let us not do that. Let us devote equal time to our hospitals. I know probably the teaching environment in our hospitals is not too good, but you can do what you want. If you are determined enough, you will be able to see and learn everywhere. Ask questions, don't be afraid. But ask questions only after you have read a little bit. Make effort, right? It's not, that's all about IOL, that's all about the cataract surgery, in terms of how to do the cataract surgery, blah, blah, blah. What is left is to study the complications of cataract surgery.
अबे यार